I had a really interesting conversation a couple of days ago with one of my supervisees, and it highlighted something that many of us get wrong in terms of our approach to the management of people who are at suicide risk. In essence, she had a client who she'd been managing for a long time, and he's had a long-term, low-level suicidal ideation. He's got a plan, the plan is lethal, he's able to guarantee safety and say that he's not going to do anything. But something changed. Between the last session and this session, he lost his job and he had a significant conflict with his partner. My supervisee is obviously worried. His suicide risk level is higher and she wants to do something. She wants to call the police. She wants to refer him to hospital. She wants to do something to acutely manage his risk. But the question is not what the level of risk is. The question is, what are the available responses? And we have a response that sits on a hierarchy. We try and manage that hierarchy as best we can to the suicide risk spectrum. So let's go back to the beginning and think about that suicide risk spectrum. At this end of the spectrum is the lowest level of risk. No one is at zero level of suicide risk, including you watching this video right now. All of our clients are at risk of suicide, and we need to be managing and monitoring that risk as part of our job. Through this level, where people are acutely unwell and are planning to do something to kill themselves immediately. That risk has 1,000 points of gradation, but our response doesn't. Our response also sits on a spectrum. At this level, we use watchful waiting. We observe, we monitor, we look and see what we can do. At this level, we hospitalize people to manage the acute risk during the acute crisis. There are not 1,000 points of gradation. Starting with low-level response, moving up to breaching confidentiality. Sometimes we refer people back to their GP. Sometimes we breach confidentiality and inform a significant other in order to guarantee safety. That carries risk. It carries risk for relationship, it carries risk for rapport, and it carries risk for discontinuation of treatment. So we use that elevated level of response if the risk is outweighed by the benefit of reducing the harm. The next level up from that, we can call out a police welfare check. We can send the police out, they can knock on the door and see if a person is okay. And then the next level of risk response above that is hospitalization. There's a handful of things we can do in the middle. We can refer people to their GP for medication review, we can send them off to a psychiatrist, we can try and engage their social network, we can try and manage their underlying mental illness. We can do all of these other things, but effectively, in terms of our response to suicide risk, we only have a number of options. When the level of risk escalates, the question you need to be asking yourself is not, how do I escalate my response? The question you need to ask is, has the level of risk escalated to the point that the next level of response is justified in terms of the risk that it will carry versus the benefits that it's going to bring?